It's now my privilege to call to the podium Marielle Jessup for the final talk. American Heart Association is not a kingdom, so she can be a queen, but she's just the president of it. Thank you so much.
Thank you. Thank you very much. It's my pleasure and honor to be here and also to be the last speaker. My job is to talk about why atrial fibrillation in heart failure patients is so deadly. Epidemiologists have agreed for several years that atrial fibrillation in heart failure patients is associated with a higher mortality. This was a matter of debate for quite some time, but the overwhelming evidence has now suggested that, in fact, having atrial fibrillation in the setting of heart failure is associated with a higher mortality. So the focus is now to understand the reasons behind this mortality effect. I'm going to show you a number of studies that are examining the associated conditions of patients with atrial fibrillation and heart failure. First is the study coming out of the Minnesota group, where they look at a large population-based cohort study of which more than 2/3 of HFpEF patients had atrial fibrillation prior to, concurrent with, or subsequent to HFpEF diagnosing, underscoring the interplay of these two conditions. Oops. As you can see, this is points out how many patients actually had prior atrial fibrillation, those patients that developed atrial fibrillation concurrent with the diagnosis of heart failure, and those patients that had atrial fibrillation concurrent with their ongoing diagnosis of heart failure. So it's a wide splay of the population. And if you see mortality or the ongoing atrial fibrillation as competing risks, you see that a growing group of patients either succumb to atrial fibrillation or die. What they found in this study is that at the diagnosis of HFpEF, patients with prevalent or prior or concurrent atrial fibrillation were older and had larger atria, worse diastolic dysfunction, higher BNP levels than those in sinus rhythm, consistent with more advanced heart failure. Development of incident atrial fibrillation was associated with older age, hypertension, renal dysfunction, left atrial dilatation, and diastolic dysfunction at the heart failure diagnosis. In a second study looking at Medicare beneficiaries, that is older patients with heart failure and atrial fibrillation, this study analyzed over 27,000 patients with heart failure admissions between 2006 and 2008. This was part of the American Heart Association's Get With the Guidelines heart failure program. What they found, as you can see, if they divided up the population into heart failure with no atrial fibrillation, those with pre-existing atrial fibrillation, and new onset, what you can see is mortality was highest in the group of patients with pre-existing atrial fibrillation. Likewise, heart failure readmission was highest in this group, stroke admission was highest in this group, and other cardiovascular readmissions certainly tended to be higher. And again, if you look at the outcome with cumulative incidence of post-discharge mortality, you see the patients with pre-existing atrial fibrillation did more poorly than the patients with new onset, and certainly better than those that did not. In a third study that was published just last year, looking at atrial fibrillation patterns and risk of subsequent stroke, heart failure, or death in the community, they classified patients that had an incident of atrial fibrillation and then watched what happened to them over the subsequent 2 years. So in the top group, you see they had atrial fibrillation without any recurrences in 2 years. Then they had a patient that had atrial fibrillation with 1 recurrence, patients with sustained, patients with indeterminate, meaning they really didn't know what happened completely, and insufficient data. So they divided up all the patients into these classifications. And sure enough, there were a variety of incidents that happened, but certainly the incidence of stroke was highest in those where it was first detected or recurrent, that the stroke occurred more in those with sustained or recurrent, and the onset of heart failure occurred more often in those with sustained or recurrent. They concluded that in their community-based cohort, few individuals with newly detected atrial fibrillation presented without an early-term recurrence, yet their long-term prognosis appeared better than for individuals with either recurrent or sustained atrial fibrillation. So we're beginning to see a pattern of whether it's a lone onset of atrial fibrillation or recurrent, that this determines not only the incidence of heart failure, but stroke as well. In the RELAX trial, which looked at PD inhibitors in HFpEF, they looked at the impact of atrial fibrillation on a variety of factors. And what they found is that as compared to the patients with HFpEF and sinus rhythm, the patients with HFpEF and atrial fibrillation had higher levels of NT-proBNP, higher levels of aldosterone, higher levels of endothelial-1, higher levels of troponin, slightly higher incidence of uric acid, and a non-meaningful increase in C-reactive protein. And so they concluded that HFpEF patients in AF were older and exhibited worse left ventricular systolic and diastolic function at rest, more severe neurohormonal activation, and greater impairment of exercise capacity, which I didn't show you, compared with HFpEF patients in sinus rhythm. So I've painted a picture that patients with atrial fibrillation tend to have worse heart failure, they're more symptomatic, they have more activation of neurohormones, they're more impaired. There's some other disturbing information that's coming out about atrial fibrillation, and that's its impact on cognitive function. This was a paper that came out of Italy last year that looked at brief episodes of silent atrial fibrillation and their ability to predict clinical vascular brain disease in diabetic patients. What they looked at is along the x-axis, you can see the atrial fibrillation burden, and on the y-axis, the number of silent cerebral infarct number, so that the more atrial fibrillation that occurs, the greater the incidence of cerebral infarcts leading to cognitive dysfunction. And in fact, they showed this very disturbing picture of the patients that had silent AF episodes, which they called safe patients, versus those that had no silent atrial fibrillation, and plotted this against stroke-free survival. And you can see that despite anticoagulation, there was a growing incidence of both stroke as well as concerns for multi-infarct dementia. There's a variety of other papers that are becoming more noticeable in the literature, looking at episodes of cognitive dysfunction or silent stroke after atrial fibrillation ablation as well. As a final testimony to what a vicious comorbidity atrial fibrillation can be, I will show you this paper that really examines the effect of cardiac resynchronization therapy, CRT, in patients with heart failure. I think it's a particularly nice paper because they broke it down into the blue line of sinus rhythm, the red line of atrial fibrillation treated with drugs, and the green treated with atrial fibrillation and ablation. And these all were patients treated with CRT. And I think what you can see is that the patients that, despite receiving CRT, were treated with drugs did least well compared to the patients in sinus rhythm or those treated with ablation. And they broke it down further so that if you look at the impact of total and cardiac mortality in the patients after CRT, at the top is patients that were in sinus rhythm. Next were patients with atrial fibrillation treated with drugs. You can see the beneficial impact of atrial fibrillation treated with AV nodal junctional ablation. And in the bottom half of the slide, looking at sinus rhythm, atrial fibrillation treated with drugs, and atrial fibrillation treated with AV nodal junctional ablation. So that we're getting an emerging picture of the lethality of atrial fibrillation, probably contributed to by the drugs we use to maintain sinus rhythm. Furthermore, CRT in itself, in the patients with ongoing atrial fibrillation treated with drugs, showed no beneficial impact of left ventricular remodeling, very similar to the story we heard after atrial fibrillation ablation. So that the group of patients that had CRT and atrial fibrillation treated with AV nodal ablation had progressive beneficial remodeling, whereas the patients that were treated with drugs despite CRT did not. So I would conclude by saying, why is atrial fibrillation in heart failure patients so deadly? There's more atrial and ventricular remodeling in patients with atrial fibrillation. There's more activation of neurohormones in atrial fibrillation. Heart failure is more advanced in patients with heart failure, with atrial fibrillation. Hospital admissions and stroke are higher in patients with atrial fibrillation. There's less reverse remodeling response to CRT in patients with AF. And there's disturbing cognitive dysfunction in atrial fibrillation. Thank you very much.
Thank you very much, Dr. Jessup, for your excellent lecture. Please stay with us.
Yes.